Okay.
Welcome, everyone. Thank you so much for joining us today. March is Colorectal Cancer Awareness Month, and colorectal cancer is the third most common cancer diagnosis in America. So today we wanted to take some time to share with you some about this disease. And we wanted to bring you a panel of Prisma Health experts to discuss this disease and the preventative measures we can all take that can help save lives. So today we're going to do a few things. The first thing we're going to do is answer a few popular questions about this disease that we know the community has been asking, followed by answers to your questions that may come in through the Facebook chat. So as we're talking, if you have questions, please enter them into the comments and we will answer those as we're having our conversation. So let's get started. I want to start by introducing our panelists. So my name is Sarah Moore. I'm the social media specialist for Prisma Health, and I'm honored to be here with you today. Today, we have three Prisma Health experts with us. We have Dr. Ki Chung, who is an oncologist with the Prisma Health Cancer Institute here in the Upstate. We have Dr. Cedric McFadden, who is a colorectal surgeon, also based in the Upstate. And we have Dr. Matt Nodelman, who's a family medicine physician with Prisma Health Family Medicine in the Midlands. So today, we're really talking about this disease from all aspects, from the preventative aspect to treatment if we do find cancer in the colon. So let's get started. First, let's start with the basics. And Dr. McFadden, I'm going to give this question to you. So let's talk about what is colon cancer and how exactly does it develop?
So colorectal cancer is a disease of the large intestines. The large intestines is the last part of your gastrointestinal tract. So the foods that you normally eat, they pass through the mouth, through the esophagus, through the stomach, through the small intestines, and then through the large intestines. The colon is part of the large intestines, but it's not the only part of the large intestines because the large intestines is made up of the colon and the rectum. So the short answer of the question is colorectal cancer is a disease where a polyp is allowed to transform into a tumor, a malignant tumor, a growth, within the large intestines that then has the capability of getting larger and spreading to nearby or distant organs. They generally start as small polyps, and these are just small bumps, as I like to describe them, in the inner lining of the large intestines. If left there to grow, they can again grow larger, they can change and then become cancerous. And that underscores the importance of raising awareness to this conversation we're having today for colorectal cancer awareness so that we can encourage more people to get the test, find these polyps before they have the opportunity to become a cancer.
Wonderful, thank you. So this is really not something that maybe folks are comfortable talking about. It can be a little awkward to talk about that area of your body. So is this something that we should encourage people to talk about more and to bring up, especially maybe to their primary care provider, somebody that they see a little bit more frequently than a specialist? So Dr. Nodelman, I'll address that question to you. How should people bring this up with their primary care provider, and what kind of signs and symptoms should they be looking for at the outset?
Yeah, definitely. That's a great question. And I think it is important because it may not be the easiest thing to talk about, and having conversations about cancer in general can be quite nerve-wracking for folks, and definitely understandably so. But I do encourage people to routinely discuss things like this with their primary care doctors, and the reason for doing so is that the goal here is that we want to do screening for colon cancer, and we want to try to catch things in before they happen, and in their early stages when you have the smaller polyps like Dr. McFadden was alluding to. But I do think that patients should bring these things up to their primary care doctor, particularly if they have symptoms they're concerned about. And things that we would want to know about would be, change in their bowel habits, if they start to, get blood or change in appearance of their bowel movements, if they have significant weight loss without trying, or any family history of colon cancer would definitely be things that, we would want to discuss with them. But that's also part of something that as primary care providers, we want to sort of start and initiate that conversation with them as well, to kind of open up that avenue for them to talk about that with us.
Wonderful. So, Dr. McFadden, you kind of alluded to this a little bit earlier, and I want to ask you, Dr. Chung, how do we prevent this? What screenings are available to people? Who is eligible to get screened? And how often should folks get screened?
Well, the best prevention is screening, of course. As far as preventing altogether, there have been multiple studies that have looked at dietary modifications, looking at certainly weight loss and things like that could contribute, given that there are some very large studies that have demonstrated that high BMI, smoking, tobacco use, all these things, these unfortunate things that individuals do may be contributing to colorectal cancer. But beyond that, I think screening is the best way to identify disease before it is known, as Dr. Nodelman has mentioned. And as far as the guidelines, again, there are many guidelines that are available, both online and published. The American Cancer Society recommends starting at age 45, and that number, of course, is arbitrary and continues to go down. So the starting of screening should be at age 45 and should extend to 75 with discussion beyond that, 75 to 85. And again, given the lifespan of individuals after 85, it's more controversial, and many would not recommend consideration of screening thereafter in that age group. But as far as the screening itself, there are many mechanisms. There are many ways to do this screening. Again, there's FIT, which is the fecal immunohistochemical testing, and that's looking at hemoglobin levels. There's either a quantitative test where they can actually tell you how much hemoglobin is in the blood, which is the reflection of the red cells quantitatively, or it can be a qualitative study where it says yes or no. We prefer a quantitative if you're going to do a FIT study, and that should be done on an annual basis as one of the screening possibilities. There's also guaiac testing, which is the classic that was used in many family practice and other primary care physicians' offices, and that's a little less sensitive and specific, but nonetheless is another screening technique that is often done either an annual or every 3 year, depending upon which society you look at. And then, of course, there's a more modern test called Cologuard, which is basically, it's a DNA FIT test. So it's also looking at DNA mutations, methylations, specifically identified in colon cancer cells, identified in the stool. And again, it's a little more cumbersome because you have to have a huge sample of stool sent. But nonetheless, it is more sensitive and specific, and that can be done every 3 years as one screening choice. And of course, the standard choice is colonoscopy, and then there's sigmoidoscopies. There's even rigid ones as well. I personally like the colonoscopies, even though it's more cumbersome, obviously, because if any of those other screening tests are positive, then they're going to absolutely have to have a colonoscopy anyway to identify a polyp or potentially a cancer as well. And so that is the best way to help prevent. And again, many, many studies you could look at. The national polyp studies published in the New England Journal of Medicine a good 30 plus years ago by Dr. Winterworth demonstrated the benefit of doing colonoscopies, reducing that risk of developing colon cancer by 95% by removing these polyps, which are the precursor for all of these cancers. Again, colonoscopies themselves are not perfect either. There are, of course, flat lesions that may be missed sometimes, and it's not perfect, but nonetheless, that's what is recommended. And these recommendations as far as follow-up colonoscopies and follow-up studies are a reflection of many things, and it's complex. Of course, if you have a family history, if you have underlying inflammatory bowel disease like UC or Crohn's, obviously those patients should undergo more frequent screening evaluations. If you had polyps before, of course, that's an antecedent reason to do more frequent colonoscopies, et cetera. So individual experiences will differ depending upon what the situation is. But in general, everybody should at least undergo screening colonoscopies or these other studies to identify the disease, because this is a problem, and we're identifying it much more frequently in younger patients. In fact, it's rising at an alarming rate in those patients under the age of 50, men more than women, rectal more than colon. But again, this is a problem.
And I do want to talk about that in a little bit, because as you mentioned, that is a problem, and it is something that we're seeing an increase of. But I want to talk about the colonoscopy first, because I know when you talk about the prep and just everything that goes into it, it can be intimidating to people. And so Dr. McFadden, I wanted to ask you, what can folks expect if this is something that they're due for, or something that their primary care care physician recommends? What can they expect from this procedure?
Well, I think what you can anticipate from your standpoint is a great nap. You have a colonoscopy, it is probably one of the best naps you'll have. But it's a very straightforward test. It's a 30-minute procedure. You get an IV, you get some sleepy medicine, and for all you're concerned, you wake up. During the test, we place a long flexible tube that has a camera and a light on the end of it. It allows us to look at the entire lining of the large intestine. We're able to identify, and if we see any, we'll take away any polyps that are present. The procedure itself takes about, again, 25, 30 minutes to get done. And you're able to that day go home and eat whatever you want. So that precludes that conversation beforehand regarding the prep. The day before, it's very important that you clean out the bowel. There's no way around it. There are lots of different options. Some are better than others for certain people, but ultimately it's the same intended goal. We got to see what's on the wall. So we have to take the paint off the wall to see what's underneath the paint. So it's very important that the prep is done. Instructions are followed, but it's not as terrible as you may think it is. There are ways that you can improve your prep experience. One of those is by drinking it cold, drinking it like a normal beverage. Don't drink lukewarm, salty brine, drink cold, salty brine, right? And it actually makes a difference in how well you can get it down. But also, if you take a moment, if you've had issues in the past with tolerance of this, there may be some medications such as some anti-nausea things that we can give you in kind of preparation for that. But once you're done with the test, you'll get a report. It'll tell us kind of if we found polyps, if we found something, and then we'll come up with the game plan of kind of when we do this again based on what we found. And I want to bring up something that Chung said earlier about those home tests. If you get a home test, like I said, you're going to be offered a colonoscopy. But also, if you choose to get one of those other types of tests that are not a colonoscopy, you may want to check with your insurance and your funding, because that may change the type of colonoscopy that you get. If you have no symptoms at all and it's just your magic age, you're going to get a screening colonoscopy, a routine test. That's coded a little bit differently from a test that's done because you had a positive fit or positive Cologuard. And often we have to go back and forth with either insurance companies talking about, well, it was my first colonoscopy, but you had the colonoscopy because you had a positive test. So have those conversations with your insurance company, because it can be a little bit of a challenge after the fact in getting so that the same coverage you'd have gotten for a routine screening test, as opposed to getting your test because you had a positive Cologuard or a positive fit test.
So really, we want to make sure, that folks are communicating with their physician about if it's something that they're concerned about, if it's something they're interested in. Make sure your physician's aware, and that way they can make sure that you get what you need in the right way that you need it.
Absolutely.
Awesome. I'm glad you talked about the prep a little bit. We did get a question about the prep, so thank you for giving those tips for how to make it go down a little bit easier. I know that's something that is a common concern for a lot of people. It may not be the most fun thing you do, but it's a very important thing to do in order to make sure that your test is accurate.
Absolutely.
So if there's a situation where cancer is found during a colonoscopy, what is the next step? Is that surgery? Is that chemotherapy? Dr. Chung, can you speak to that a little bit?
Well, that's a complex question. If a cancer is confirmed by colonoscopy, there are some factors, of course, that the surgeon, like Dr. McFadden, would like to know, whether it's obstructing or not up front. The anatomic location makes a difference in terms of the therapeutic approach, and potentially the need for staging studies, including CAT scans, to make sure that it is isolated to that area. So there are many features in that determination. So it's an open-ended question in a way, but for a typical colon cancer identified in an asymptomatic individual with a lesion that's, say, in the right part of the colon or the cecum, biopsy proven that it's a cancer called an adenocarcinoma. Again, most of these tumors, 95%, are adenocarcinomas, which is the Greek word for gland-forming tumor, as opposed to a few other rare tumors that can also be identified in the colon. So in that in that setting, of course, the patients are seen by the surgeon. Staging studies are often done with a CAT scan of the chest, abdomen, and pelvis to make sure that there is no other sites of disease. Blood tests can be done, including a tumor marker called a CEA, or carcinogenic embryonic antigen. And from that, you can get a preliminary stage of the disease. And if there is no evidence of disease outside of the colon, then typically the colorectal surgeon takes care of it from that standpoint in terms of surgery. And again, depending upon other anatomic considerations, it could be a simple right hemicolectomy, extended right hemicolectomy, depending upon the situation. And then we would talk afterwards on the basis of the staging system, which we can go over another time, but there's 4 stages, 1, 2, 3, and 4. And that stage helps dictate the next steps in terms of risk, prognosis, and what kind of adjuvant or additional therapies we can give to reduce the risk of this returning.
Wonderful.
But that's an open-ended question.
Yes, certainly. Certainly depends per person, but I think the real message is, what get screened when it's recommended to get screened. And that's really, that's the best chance for prevention and early detection.
Absolutely.
And I think it's important to sort of point out the fact that a lot of what happens doesn't happen in a vacuum. While you may have a colonoscopy with me, you're going to have a whole team of folks that are going to be helping make those decisions. And that's one of the benefits of working at a great health system. You have Dr. Chung, and you have your primary care doctors, and if the radiation folks who need it, they're part of the conversation. So it's not a unilateral decision that's made. We're not making decisions for the patient. We have conversations together. We share notes, and we have conversations back and forth to help make sure that the plan is unique and specific for you.
Wonderful. Wonderful. So I do want to go back to what was an earlier conversation about seeing colon cancer on the rise in younger people. So for people that kind of fall, we talked earlier, 45 is kind of the recommended guideline for colonoscopy now. But for people who are younger than that, how should they, if they have a concern, Dr. Nodelman, how do you recommend that they address it with their primary care physician? Should they share things like family history with you? How do you recommend they kind of start that conversation with their primary care physician if they have a concern and they're younger?
Yeah, I think that, that can be a little bit complex in a way, because the guidelines that we sort of follow to recommend what age people should do this are kind of constantly evolving. And so, not that long ago, we were sort of looking at age 50 as being the starting point, and now we're kind of moving that younger and younger. But I certainly think that, the primary thing that we would look at to recommend earlier screening for somebody would certainly be any family history of colorectal cancer or certain types of polyps that they may have. And the reason for doing that is that if a family member were to have colon cancer at a young age, then if they're a first degree relative of you, such as a parent or sibling, you would be therefore a little bit more likely to have colon cancer at a younger age. And you may be a person that we would recommend earlier screening for. And that's something that I think is definitely something as a primary care doctor that we would love to talk to you about and would encourage you to bring up if you have any family members that do have colorectal cancer, because we want to make sure you get the screening at the appropriate time, again, to make sure that we're catching things earlier or before they occur. Constantly we're kind of reviewing, as they change recommendations for when to screen, we can help you navigate the newest information and try to come up with the best decision, based on you and your family history. And certainly if you have any symptoms that are worrisome that we were kind of discussing earlier, that would sort of want us to get a colonoscopy for a different reason, maybe not for a screening test, but, maybe as a diagnostic procedure to figure out what's going on.
Yeah, I agree with all that. And I agree that we need to remove that stigma that we shouldn't talk about cancers of the colon and other cancers as well, and just bring this out in the families. And the other thing is we can't ignore these young 30, 40-year-olds who have some blood in your bowel movements and just attribute it to hemorrhoids, because we're seeing these patients with rectal and colon cancer that are being ignored for a long period of time, and unfortunately sometimes too late. This is something that needs to change.
Mm-hmm. And I think, that in some ways that's across the board with all cancers. And that's one of the advantages of establishing a primary care home and having a relationship with that primary care physician who can kind of get to know you and get to know your specific body, and be aware of any of these changes that may not necessarily flag for you or flag for a more serious condition, but have somebody who's kind of an advocate and on your side. Would you agree with that, Dr. Nodelman?
Yeah, definitely. And I think that, knowing the patient and sort of their family, and then also just knowing their personal preferences, I think just looking at it from a different standpoint of helping them navigate the different screening options and figuring out, which one's going to be the most suitable for them. And, ideally, we would certainly want everybody to go ahead and get the colonoscopy. That's sort of our gold standard test, and that would be ideal. But, not everything is an ideal world, and we need to figure out what's the most practical for each individual. And we can help navigate, which tests are going to be best for certain patients, and maybe they're not recommended for you if you have, maybe you've had a polyp in the past. You may need to get a colonoscopy and not one of these other tests. And so those are definitely things that, I would recommend talking about with your primary care doctor. And from my experience, those are things in our office that we're looking at all the time. And we're constantly kind of making sure that we have everybody up to date with their screenings and figuring out the best options for them.
Wonderful. So in addition to kind of seeing this uptick in younger people, we also know that colon cancer disproportionately affects communities of color. And Dr. McFadden, I wanted to ask if we know maybe why that is, really if we know why it's affecting younger people and maybe minorities or communities of color, and what advice you have about this disease specifically for those communities.
Yeah, so loaded question, and we're going to answer that in a very succinct manner. The short answer is there are multiple reasons of why that may be the case. We're seeing the fact that African Americans are 20% more likely to be diagnosed with colorectal cancer, 40% more likely to die from colorectal cancer. The conversation generally starts the piece on the genetics. Is there something in the family history that makes it more likely? Is there something related to the other risk factors of colorectal cancer, such as diet? Diets that are high in red processed meats, diets that are high in fats. In African American community, research has shown that diets can be obviously in some cases very unhealthy, which could then lead to perhaps more cancers. Not just colorectal cancer, but any cancer. Obesity is also a risk factor that may be higher in African American community. There may be other environmental factors. But also, we can't ignore the fact that there's some determinants, we refer to them as social determinants of health. It's the access to not just healthcare, but quality healthcare. It's access to a conversation between the doctor and the patient that where both parties understand each other. There's an elimination of sort of unconscious biases. There's a ability of the patient to get to the doctor, to be able to pay for the medication or have the procedures. There's a whole litany of reasons why that could be the case, that they're inappropriately or disproportionately affected. And it's the ability to get the colonoscopy. Getting a colonoscopy can take a lot of work in certain cases. It can be challenging to navigate the system, to show up for the test, to get the ride from the test, to get the prep for the test, and to be able to pay for the test and the anesthesia. All of that can influence someone's ability to get early screening, to find these polyps before they become cancerous, and not just cancerous, before they can become advanced cancers. And that can then lead to a poor survival when it is found that way. So my recommendation has always been, even before we move the average age to 45, for African Americans to get screened at 45, but also to know your family history and to do the things that we know we can do, such as the diets, the exercise, the elimination of smoking. Those are things that are important. And then also to not ignore those symptoms when present. And often I've had patients come to me and say, I would have had the test if they had offered it, or I told them I had these problems and I was ignored. So I say continually talk with your doctors. Having that primary physician is great, but if they're not listening to you, keep saying it, keep talking. And unfortunately, sometimes it means it may not be the best fit. There is a good fit for you as a doctor. So you have to find that doctor that will listen to you and that you can have that open dialogue to make sure that we're finding these things sooner.
Is there any sort of indication that diet or something else like that would also be one of the reasons that we're seeing this in younger folks, and we're seeing that kind of median age drop. Do we know why that is?
There's a lot of research ongoing in that, and there's a historical paper in JAMA Oncology from 10 years ago that looked at 18,000 nurses aged 25 to 42 and followed those patients over 20 plus years and looked at the development of colon cancer in that cohort and found that the BMI was the #1 factor independent of everything else. So every 5-point increase in your BMI increased your risk by 1.2-fold of developing colorectal cancer. And so that is certainly probably one of the contributing factors, but probably not the only contributing factor. And of course, the other big research that is subject to a lot of grants in the NCI now are the microbiome. So the gut is teeming with trillions of bacteria. And obviously, these bacteria play a role in our digestion, immunity, and other things. And there's probably a change in the microbiota in those patients who develop cancer, whether it's age-related, whether it's race-related. There are some studies that have demonstrated clear differences in the spectrum of bacteria in those who are less than age 50 versus older. Again, teaming with research right now to figure out some of these things that might be able to be teased out and as additional preventive measures as well. But right now, overall, of course, we don't know exactly why the reason is that younger individuals are developing colorectal cancer. And I'm sure the diet and all these things, the processed foods, et cetera, are certainly playing some role.
Mm-hmm. So we do have one question, and I imagine the answer is probably discussed with your physician. But if an individual has already had cancer and they have a test that says they're predisposed, is there a recommendation for when that individual should start getting screened?
It depends upon the situation. If they were diagnosed with colon cancer, and it all depends on the situation. If they were stage 3, they received adjuvant therapy. They were followed for a 5-year course, and obviously the risk is reduced, but still present. They should still undergo colonoscopy screening studies. I don't think there would be a reason why they would discontinue screening evaluations if they had cancer identified previously. I can't think of too many reasons why that would be, unless there was the patient was 95 and again they were bed bound and there was no other indication to do screening studies.
And for people who have that family history of genetic or of colorectal cancers, we advocate screening earlier than 45. Oh, yes. So if mom was 40 when she was diagnosed with colon cancer, you're not going to wait till you're 45 to begin screening. So you're going to begin screening 10 years before she was diagnosed, so 10 years before she was affected, which is why it's very important that we have sometimes these uncomfortable conversations with our family members about, exactly what type of cancer. You say it was belly cancer, but was it colon? Was it pancreas? And that can be hard to find, especially in families that either don't know or don't want to talk about it. Digging a little bit deeper regarding, because that's going to affect when you should, and your children should begin these screening tests. So, definitely ask those really tough questions and get to the heart of it so you can know when you should begin screening.
So definitely have an open dialogue, with your family, as challenging as that can be to kind of bring up those awkward conversations, making sure that it's, they're aware that it's for your health and the health of your children. And, it's really to make sure that everyone in the family stays healthy for a long time. Okay, well, I think that looks like all the questions we have from the chat, but wanted to just kind of open the floor if you all had any kind of final thoughts you wanted to share, wanted to give you an opportunity to do that.
Well, one of the important pieces of this whole conversation is colorectal cancer is preventable. Mm-hmm. So this is not a cancer that we don't know and we can't prevent, such as brain cancer or such as some of the other cancers like certain sarcomas and things like that. We have tests such as the colonoscopy that can find these cancers even before they're cancers, and we can prevent it, which is, again, underscoring the very importance of the simple screening test like a colonoscopy. So again, that's one of the key messages here, We don't want you to wait for symptoms. Get the colonoscopy, get the screening test. And if you have symptoms, get a colonoscopy. So get a colonoscopy is sort of the key takeaway from today.
Absolutely. Absolutely.
Yeah, and I definitely agree with that as well. And I think as a family medicine doctor, I think that, for me, I guess sort of the key to getting that colonoscopy and getting that screening test is, encouraging people to have regular follow-up with their physicians and sometimes taking that extra step to, establish with a primary care doctor, even if, your family and yourself are in very good health, and you don't seem to have, a lot of issues, we still would love to see you, on a yearly basis and be able to kind of talk through some of these things to make sure that you're getting sort of the screening and everything else that, that you would need. That's sort of the first step in the door to make sure that we're getting you the testing and everything that you need. And so, we definitely kind of encourage, you going to routine checkups and things like that, even when you may not be ill or have a problem, because we may not always have time to really dive in and address those issues, when you're coming in for the problem visit.
It's a great point. It's a great point. Well, I want to thank you all for your time today.
Absolutely.
We got one more question, which I think we did kind of address this a little bit earlier, but it just says, when do you recommend Cologuard versus a colonoscopy? And I think, all of your advice is that really, colonoscopy is the gold standard, and that's, really, that would be kind of the primary recommendation, especially because if this at-home test does find something, the colonoscopy is going to be the next step. Anyways,
but there's some people that no matter how much we jump up and down are not going to get a colonoscopy. And so the best test is the test that the patient will get. And so the Cologuard occasionally comes in handy in patients that refuse to colonoscopy or perhaps have had problems with prior colonoscopy. Either they've had, we call it twisty or a tortuous colon where it's difficult to get around. That may be an indication to say, well, let's try another option. But please understand that if you've had symptoms or if you've had prior cancers or polyps or family history, those are not the appropriate tests for you. Those other tests are for average risk patients. So if you have bleeding, you should not be getting a Cologuard. You should not be getting a FIT test. You should be getting a colonoscopy. So that Cologuard is for the average risk patient who doesn't have symptoms, no family history of problems, no prior personal history of polyps. That may be appropriate to get the Cologuard testing done.
Agreed.
Yeah, and I'll just echo that as well. What Dr. McFadden said is that, we want you to get a screening test done if you're a good candidate for it. And again, that's for average risk individuals. But, if logistically, going through the process of getting the colonoscopy, there could be multiple barriers, that Dr. McFadden alluded to earlier, when you look at folks of lower socioeconomic status or just lower access to getting that done, we want you to be able to complete the test that's going to be the most likely to be done, and the one that, and sometimes that is an at-home test or things like FIT tests we can even provide for patients while they come in for their appointments and send them home with the kit. And so sometimes for certain individuals, that's easier for them to complete as opposed to going through the process of getting the colonoscopy. But again, I think kind of taking a step back, I think just having that conversation with us and helping and allowing us to kind of navigate that is sort of the best recommendation.
Wonderful. That's great advice. Well, I do just want to remind everyone watching live that if you watch this live and you think of a question later, you're welcome to put it in the comments and we'll have our experts answer it offline. Or if you're watching this on replay and you have a question, we'll be able to answer that as well offline. So again, I wanted to thank you all for your time today. This is a really important topic, one we really want to hit home all months of the year, but especially in March when it's Colon Cancer Awareness Month. So I thank you all for sharing your knowledge, sharing ways that we can prevent this disease and hopefully save lives with the information that you shared today. So I thank you so much. Thank you all for watching and participating with your questions. They were great questions. And we look forward to seeing you back here live very soon. All right. Thank you, guys.
Thanks so much.
Thank you.
Thank you.